Okay, so what we're going to do today is we're going to go over renal anatomy. This is basically just a real basic anatomy review. It's not anything more complicated than what you did in school, but we need to just go over some of the key elements to remember with the renal anatomy and some of the main concepts that we want to have down. Some of this stuff will be covered lecture by lecture, but I just wanted to give you a small kind of review to get the juices flowing here. All right, so here's the basics of the renal anatomy, right? So you've got your adrenal gland, right? Sits on top of the kidney. You also have the kidney itself. And then in the middle here on either end of the kidney, you have what they call, let me point here. This is called the hilum. Okay, right in this section is the hilum. And we'll talk a little bit about that area also. Also remember that the kidneys are retroperitoneal, so they actually sit behind that peritoneal sheath. And then you've got your ureters, the urinary bladder, the urethra. It's good to know kind of where these kidneys live. They live, you know, anywhere from, let's say, T12 to L2, L3, somewhere in there. So here you can see they've got L3. So yeah, about L3. The right kidney is going to live just a little bit lower here because what they're not showing here is this huge liver. So that's kind of pushes that right kidney down. We'll talk about more about blood flow and urine flow in a bit. Okay, so what does the kidney do, right? Kidney's a big deal. We've got two of them for a reason. They filter blood, they regulate your pH, they regulate your blood volume, they regulate your blood pressure, they regulate osmolality, and they regulate and produce hormones. So what is osmolality? Osmolality is basically just an indication of how much stuff is in a solution. So if I've got a cup here and I've got a lot of solute in that cup, right, I'm going to have a higher osmolality than if I have a cup that has nothing in it. So osmolality is something that people struggle with, but it's really a pretty easy concept once you get the gist of it. All right, so where do the kidneys live? Well, they live retroperitoneal. So what does that mean? They live on our back, right? If you ever took a kidney shot, you know exactly where the kidneys are. Okay, so this is the peritoneum, this really thick covering that keeps all our organs in our body, right? This is what gets inflamed when somebody gets peritonitis. So the kidneys live behind here. There's this big mesh sheeting that separates the kidneys from the rest of the organs. So that is important to know. Really, the rest of this stuff here is just kind of ancillary stuff. I just wanted you to understand where they live. All right, so here's a laparoscopy. So they've gone in through the belly. You know, you poke those laparoscopy holes, usually about 4 different holes, sometimes 3, biggest hole being the camera, and they're looking back at that retroperitoneal space. Obviously, you can't really see the kidney. It's still covered with fascia as well, but this is what it would look like from the abdomen. So if we've poked in through the abdomen and we're kind of looking around with our camera, we can see that kidney kind of pooching out, but we're not going to actually be able to get to it unless we get into that retroperitoneal space. Okay, so also another important thing to note is that the kidneys are protected very well by the floating ribs. So you've got basically your 12th and 11th ribs. Those are protecting the kidney posteriorly. So that's just another little kind of idea of how essential these are. And they were built to be protected for a reason. All right, so what's the hilum? So this is the renal hilum, this kind of area here. And what we've got in the renal hilum is part of the ureter. Yes, that's maybe not as important as these other structures that are here. So the renal artery, which would be colored red here, then your renal vein, which is going back, blood flow would be coming back out of the kidney, and then the renal nerve. So there's the nerve. All right. Also, you can see some other things here, which we'll get into, but the renal cortex and the calyces are also apparent there. So let's talk about the layers of fascia that kind of cover this kidney. So first, you've got this kind of external fascia. It's the coat of the kidney. It's this real fibrous tissue that basically holds the kidney in place in that retroperitoneal space, so that the kidney obviously doesn't jostle around and that it's fixed and safe in that space. Around that then, so then deep to that, you have the adipose tissue, and that adipose tissue basically just kind of insulates the kidney. It protects it from blunt trauma. And then lastly, you have the renal capsule. So this renal capsule is a fixed capsule that encapsulates the kidney, and in this case the renal capsule is like this kind of middle space here, with the adipose over the top of that, and then finally the fascia that kind of holds it in place on the very outside. If we take a cross section of the kidney, then we can see really, so what we've done is we've sliced a frontal plane slice of this kidney. Right now we can see kind of the structures that we care about here. So as we kind of break this down, you've got this cortex part, right? So this is the kind of the meat here of the kidney. That would be the cortex, okay? You've got your fibrous capsule, which we already kind of talked about. And then you have the medulla, all right? The medulla are these renal pyramids, if you will, that help us to filter the urine and turn it into a filtrate. And so those are there. Then you've also got your arteries and veins that kind of interweave throughout the kidney. Here we've got the renal papilla. Okay, so this is where all these calyces kind of get together. All these renal pyramids kind of coalesce into this papilla. And then you've got your calyces, which are here. So these calyces start here. These are considered minor calyces. And then this big portion here is the major calyce. Okay, and then that all kind of coalesces into the ureter, and then the urine flows that way. So do you work as hard as your kidneys? No, you do not. The answer is no. On average, the kidneys filter 150 liters of blood per day. That is the equivalent of filtering an entire blood volume about 30 times per day. So they are working hard. This is a 150-gallon fish tank. So just imagine that being filtered all day. Try to take each of a bucket of that out and filter it through a filtration system and then put it back in. And that's what the kidneys essentially are doing all day long. So I think that's pretty impressive. So let's track the kidney blood flow. So basically we've got here, you've got on number one, you've got the renal artery. Okay, so the blood is coming from the aorta into the renal artery. From the renal artery, then it goes into the interlobar arteries, okay, right? So the lobes of the kidney are being bathed in blood here. Then you have something called the arcuate. The arcuate arteries, which are right here. These are these smaller arteries. And then you've got the interlobular arteries, which are in between the lobes. And then you start to go backwards. So you've gone from the interlobular arteries to the interlobular veins, then to the arcuate veins, then to the interlobar veins, and then back into the renal vein, which is this big dog right there. Okay, the nephron anatomy is really something that you have to understand. This is the money shot of renal anatomy and physiology. And if you understand the function of the renin-angiotensin cycle, you understand the function of the nephron and the glomerulus, and you are intimately related with those, you will excel at renal. I can promise you that. All right, so here we've got the Bowman's capsule, right? So this Bowman's capsule is part of the nephron. It's the first part of our nephron. That capsule creates kind of a back pressure. There's a lot of different pressures that are created in the capsule. We'll talk about that later in some of the later sections about how we actually filter the urine and what's important with that Bowman's capsule in that space when it comes to like losing proteins and osmolality. But for right now, we're just doing a quick overview so that we're all on the same page here. Okay, so going into this glomerulus, you have the arterial coming from the renal artery. So there's like this big dog renal artery here. You've got this little tiny arterial that goes in there. And that is where the blood is filtered into a filtrate, which you, which would be urine and solutes that is then thoroughly kind of gone through, and certain compounds are extracted and certain compounds are kept. And then here we have the arterial that comes out from the glomerulus. So you have your efferent and afferent arterial. The afferent arterial is the one that goes in, and then you have the efferent arterial, which is your exit. All right, and then all of these arterioles kind of snake around. They snake around this loop of Henle, and then there's this capillary complex that now they go into the venous flow. At the same time, this urine, this filtrate is being kind of distilled. Things are coming, things are going. We're deciding what we want to keep and what we want to get rid of, and then it's all processed into this collecting duct that then dumps into the ureter, then to the bladder, and then out of our bodies. Okay, so the glomerulus anatomy. So the glomerulus is a really important physiologic structure. Without the glomerulus, none of this works. So we've got the glomerulus kind of sits near this loop of Henle in the nephron itself. You've got your efferent arterial and your afferent arterial, okay? So blood comes into the Bowman's capsule. It is then filtered. And the blood flow, what we really need to understand here is that in this glomerulus itself, there's these podocytes which help to exchange certain things, and we'll talk about these in depth later, but this is where the podocytes live, which is on the inner part of this glomerular structure. And then you also have some capillary beds in there, and then this is the outside of the Bowman's capsule here. Let's see, we've got the podocytes, and then we've got proximal tubules here too. So that's interesting to know, because sometimes some of these cells will slip into the filtrate, and we need to know where they're coming from, because that kind of can suggest where the damage is in the kidney or in the nephron itself. So here's the juxtaglomerular concept. So that's a tongue twister, but basically what this does is it helps to regulate our filtration rate, right? So the GFR would be regulated here, and also can be, you know, it can be adjusted to compensate for either low or high blood pressure. So this is just kind of a overview of that. So you've got your efferent arterial, the afferent arterial, and then in between those two, you've got this juxtaglomerular apparatus. So the juxtaglomerular apparatus just consists of 3 different types of cells. So you have a juxtaglomerular cells. These are the granular juxtaglomerular cells. So these bad boys live right on the afferent and efferent arterioles. You also have the macula densa cells. These are living on the distal tubule. So as that tubule either expands or contracts, it's going to send signals that these cells will respond to. And then we have these mesangial cells, which are right here. And they also help to signal these juxtaglomerular, the granular juxtaglomerular cells to cause change to flow. So let's talk about that a little more in depth. So how the heck does this work? Well, it's a very complicated mechanism. I'd like to see how the heck these guys figured this out in the first place. But basically, you've got these macula densa cells, which live right here. They are kind of lining the distal tubule. So as the distal tubule either expands or contracts, it'll send information to these macula densa cells. So the macula densa cells can sense increase or decrease in sodium levels. As they sense that, they will signal to the granular juxtaglomerular cells and to the mesangial cells and tell them what's going on and how to respond. The mesangial cells act kind of as a helper to also signal these granular juxtaglomerular cells to respond to stimuli. So the granular juxtaglomerular cells, once they note that there is a decrease in volume via the decrease in sodium and chloride, those juxtaglomerular cells, the granular ones, will secrete renin. And then renin has a lot of other functions that it does. Renin will increase indirectly. It will increase sodium reabsorption. It will increase your blood pressure. It will constrict blood vessels and therefore raise the blood pressure. Now that's why a lot of these pharmaceuticals will target this mechanism, and it is important to know that so that you know how your pharmaceuticals act and why they behave the way they do. So here are 1, 2, 3, 4 different videos that I would highly recommend that you paste in your browser. You guys have, I think, about 4 hours set aside for anatomy and physiology. That gives you more than enough time to work on some of the objectives, to do the reading, and to watch these videos, which are going to make you draw. If you draw, you will remember. So if you do these drawings, you'll really remember these. So make sure that you go through all these. These are all handwritten tutorials. When you listen and you watch and you put pen on paper, you learn and you retain and you learn the concepts. You don't just memorize. All right. So what is the renin-angiotensin system? So this has been pretty much beat into your head since the start of PA school, and I'm sure since the start of anatomy and physiology, but you have to know this. If you do not know this, you cannot reason through problems. So let's talk about this a little bit. So when we talk about the renin-angiotensin system, we've got a drop in blood pressure that was noted by that big, huge, long worded complex before, the juxtaglomerular complex. That senses a drop in blood pressure. It goes through a series of reactions that then cause the kidney to secrete renin. Well, what the heck does renin do? Who cares about renin? Well, renin causes a big change in the way that the body behaves. And how does it do that? Well, the liver is secreting angiotensinogen, so ogen, right? So that is a precursor. That is a pro-hormone, right? So angiotensinogen doesn't do anything by itself. It needs to be converted. So it is converted to angiotensin 1. In the presence of ACE, angiotensin 1 is now converted to angiotensin 2. Angiotensin 2 actually does quite a bit. So angiotensin 2 has multiple mechanisms. One, it is going to target our hypothalamus and tell us that our blood volume is low and we should drink more water. So that is a good thing. We are now thirsty. We're going to increase our blood volume by actually consuming more liquid. Secondary, it is going to target the adrenal cortex, and it is going to cause the adrenal cortex to secrete aldosterone. What does aldosterone do? Well, aldosterone is going to target the kidney and allow us to reabsorb more sodium and retain more water. Therefore, sodium follows water, right? That is also going to elevate the blood pressure. And then lastly, angiotensin 2 is going to cause vasoconstriction. Vasoconstriction, you had a large vessel before and the pressure was low. Now you have a tighter blood vessel and the pressure is going to be higher. Simple physics. You should draw this. So here's another handwritten tutorial. I hope you hate these by the time we're done. This handwritten tutorial will also take you through the way that the renin-angiotensin system works. And if you really understand this, it will really help you for the majority of PA school. This is part of cardiology, it is part of respiratory, and it is definitely part of renal. So you cannot get away from this system. You better know it. All right, so let's talk about urine production. Okay, so we've already gone through all the nephron. Now we're getting ready to produce urine. This kind of brings us back to that glomerulus again. Okay, this is a really simplified drawing of this. You don't have to know the nuances yet. You just have to know the basics so that we can move forward. Then you can attack the difficult stuff. So right now, blood enters into the glomerulus. The blood is then filtered in Bowman's capsule to a filtrate, and then the other blood returns back into the flow of the body. Now, this filtrate then is further processed. At this time, tubular reabsorption takes place, so the substances that we want are retained. The substances that we don't need go into the filtrate. After that, we get rid of waste. We get rid of things that we don't need. Some stuff goes back in the body that we may need. And last but not least, we reabsorb water into the body because water is very important. And then we have our urine. Okay, so that's our final filtrate, and then that goes out to the toilet. Okay, so urine flow, basically, right? This is really basic. Kidneys, ureter, bladder, sphincters, urethra, to the toilet. Okay, so bladder anatomy. There's some things you want to know about the bladder anatomy because eventually you're going to be treating people who have problems here, and that's where we need to be receptive to what's going on. So you've got some ligaments that suspend the bladder in space. Okay, 3 ligaments that look like this. You've got your 2 ureters that go down into the bladder, and then you also have 2 urethral openings. Okay, those are the areas where the urine spills in from those ureters. Okay, problems can happen in all these locations. We're getting into a little bit more of urology, but this is overlapping with renal, so we're just going to go through it pretty quickly. And then you have your sphincters. You have an internal sphincter and an external sphincter, and if you're a male, you have a prostate that lives here in between. The difference between the male and female uro-anatomy, basically that's that prostate in the male. So the male has a prostate here, the female obviously does not. This urethra is a lot longer. This urethra is a lot shorter. Healthy young men do not get urinary tract infections for this very reason. So we need to keep that in mind. I see a lot of people that diagnosed healthy young men or healthy middle-aged men with a urinary tract infection. They start to get better and then they come back and see me because they're having another urinary tract infection. At that time, they need a digital rectal exam to tell them what's going on because they have prostatitis. They do not have a simple cystitis unless they are immunocompromised. So keep that in your mind. All right, moving on. So micturition, this is the making and excreting of urine. So basically we can go through these steps. So the bladder starts to fill. The detrusor muscle is loose at this time, and as the bladder fills, that muscle gets tighter. The urethral sphincter is contracted and the pelvic floor is contracted. Once we get the sensation to void, that means the bladder is about half full. So that cup is half full. At this point, we can decide if we want to go to the bathroom or we want to wait. So if we decide to wait, at this point, we can tell our brain to just chill out for a while and we can calm down the pons. When we finally decide to go to the restroom, then this pelvic floor relaxes and the detrusor muscle contracts, expelling urine. This is a micturition reflex. So it's just a big reflex loop that controls the stimuli to go to the restroom and then the actual event of going to the restroom. So you get a sensory signal from stretch in the bladder and the urinary bladder. That signal is then picked up by the pons. It is relayed to the cerebrum where we decide if we want to urinate or not. If we say, yes, sure, let's go for it, then we get a motor signal that causes contraction of the urinary bladder, pushing out the urine, and relax that sphincter, and micturition occurs. So that's definitely spilling into GU, no pun intended, but I wanted to give you guys that information because it kind of closes the loop. We will go over a lot more anatomy and physiology as we go through renal, but this is a quick brush up on those. If you do the drawings, you will be well prepared for the next lecture. That is it. That is all you need right now for anatomy. We will tackle the more difficult minutia as we move on further.